The second clinical inquiry activity is evidence-based practice at the point of care, and that's represented as the E in the clinical inquiry model. And that's defined the way many have defined in terms of the utilization of best available evidence combined with clinical expertise and patient and family values and preferences. So this is, if you think about it as a three-legged stool, you'll understand why this is dynamic and interactive. You can't just go in saying, okay, this is the plan and this is how it's going to be and we're not ever going to deviate from this plan. That is sort of the old model of healthcare. But the fact is, if patient and families have a voice, and they should have a voice in their care, they could change their mind and say, you know, now I'm not really that comfortable with the plan. I know we talked about that at my pre-visit 6 weeks ago, but now some other things have happened. My daughter's going to graduate from school. I really want to be there, so I don't want this procedure to interfere with that. I need to be there. So there may be some changes that happen. Along the way, of course, science doesn't sleep, so there may be new available evidence that wasn't there 6 weeks ago when this plan was made. And additionally, the clinicians may have had some changes in heart in terms of what their judgment is telling them is the best plan for this particular patient and family. So all of these moving pieces need to, it's about being adaptive, and you need to think about zigging and zagging, so to speak, on the fly all the time when it comes to evidence-based practice. And all clinicians are doing this every day. It needs to be a vital piece of their practice. This is the workflow for that. The patient-family issue problem starts it, but then accessing the evidence, appraising the evidence, and then using the evidence, because you know you want to use best available evidence to help guide your practice. The R is research in the clinical inquiry model, and that's a systematic process that's discovery-oriented. So that's really juxtaposed against quality improvement activities, because if you recall, the quality improvement is about taking something that was previously discovered and implementing it in your local setting. Research, you embark upon this activity if there has not been anything in this area, that's really truly discovering something new. It can take different forms depending on the discipline and the research questions. So, you know, historical research is very different from someone who's in cinema studies. That kind of research is very different. So the nature of our discipline changes how we take up research. But in healthcare, primarily there are two major ways to go about it. There's the primary research or secondary research. So primary research is a systematic investigation to develop or contribute to generalizable knowledge. We always want to share what we've come up with, what we've discovered. This can be quantitative, can be qualitative, or it can be mixed method. And always the plan is to publish that to the greater community. But because we deal with organic human beings or their derivatives like cell lines and tissue types, most primary research has to go through a human subject or animal subject IRB process for approval. So institutional review boards are involved, which always makes primary research just a little bit more complicated. You'll see here on this workflow, again, the same part of the workflow is the same. The patient-family issue or problem drives you going to the evidence, and you need to appraise that evidence. But now you need to obtain IRB approval. Even if you're doing it on dogs, as in a wet lab, before it even gets to humans, there are animal IRB processes that you need to go through. Then you gather your baseline, test your new knowledge, and gather your intervention post data. Now, of course, I'm simplifying. There are many, many complicated crossover research designs, but for the sake of a workflow, it's a similar kind of workflow. You have to gather something beforehand, that you have something against which to understand the results on the back end. The pre-data in primary research can often look very different, but that's essentially the goal. Secondary research is distinguished from primary research because this is where you're dealing with a pre-existing data set. So it involves a summary and analysis or synthesis of existing research. So with a secondary analysis, this is where I may take someone else's data set, with their permission of course, and ask a new question of it. So maybe it was collected for question Y, but I'm coming in with question Z, and I can use this existing data set to answer that question. So in that way, it's like a new set of lenses. You're asking a new question, you're putting on new glasses to ask a new question off of an existing data set. A systematic review is another form of secondary research because you're gathering the data that is out there in the form of published articles, even in the gray literature, and you're pooling it together and making a statement, recommendations. You're contributing to science as a result of what's already out there in the literature and pooling it together. But because in both cases no human subject content is necessary, no IRB approval is necessary. So the workflow for secondary research is you start with your patient, family, issue, or problem at 12 noon, then move down again, accessing the evidence, appraising the evidence, systematically analyze your already collected data, and disseminate your findings. It makes it look so simple, and truthfully, secondary research is as complicated as primary, but for the fact that you don't have to go to the IRB for approval. Innovation is the I in clinical inquiry, and innovation means new, but new is not always better. So for that reason, innovation always has to be paired with quality improvement activities or research, depending on the question and the innovation, so that whatever you adopt, you can say that it has been tested and has been proven to be successful in your setting. So that means, again, collection of pre and post data. And this is my daughter's wrist, cute wrist, don't you think? And we actually, when we were going on our magnet journey, we found that this was a problem in our setting, because especially with innovation, I think UCSF is not unique in this way. Medical centers are busy places, little time to sit back and smell the roses. So people have a problem and they just go and solve it. They say, look, I went to the literature, they say this kind of mattress is effective in reducing pressure ulcers, let's get it and let's see if it helps. So maybe they weren't disciplined at doing pre-data collection to sort of show the scope of their issue. They put a mattress in place, and maybe they do a little post-intervention data collection, but maybe it wasn't even aligned with what they were looking at on the pre-side. So that was messy, and that was something that we decided we had to clean up on our medical center side to be successful in this clinical inquiry journey. And so the chief nursing officer and I joked about maybe tattooing pre and post on every new hire's wrist. We ultimately decided not to do that. But I did get temporary tattoos just because at that point I thought it was funny. So it is a common theme. Pre and post is important sort of for every flavor of clinical inquiry. So this is the innovation workflow. Patient, issue, family starts it, accessing your evidence, appraising the evidence. You may need to consider IRB approval. Even quality improvement studies may need IRB approval if you're dealing with a vulnerable population. Not the norm, but it could be the case. But clearly with research you would need to get IRB approval. Then gathering your baseline data, apply that innovation, and then test it and gather your post data.